Good afternoon and welcome to the next in the series of breast cancer Q&A webinar. This is the fifth that I've done with Sharon. I'm Dennis Holmes. I'm a breast cancer surgeon, cancer researcher, and Sharon is a patient advocate who volunteers her time to collect questions from you, patients and other women who are interested in learning about breast cancer. Today's topic is HER2 positive breast cancer. Thank you for joining us. Sharon has collected a number of questions from over the last couple of weeks, and she's going to go through those questions. I'll do my best to answer them. I want to start with a disclaimer that I am a surgeon. I'm not a medical oncologist, so there'll be many instances where I might defer you or refer you to a medical oncologist who's the expert in this field. But my goal is to at least give you some tools and some guidance so that you can understand what HER2 positive breast cancer is, and that'll make you better equipped to have conversations with your other oncologists about this diagnosis and how you should be managed. Sharon, why don't you get started?
What is HER2 and what causes it?
Okay, so HER2 refers to human epidermal receptor 2. It is a protein that is a functional protein. It functions as a receptor on the surface of cells. It is a normal protein that is typically present in a lot of cells in the body. It's just that in some situations it can be overexpressed, be present in a great number. Now I want to give you a little background because I know a lot of this jargon is kind of medical, but I'm going to try to simplify it in a way that it helps people understand what a receptor is and how it all fits together. So you've heard of a chromosome. A chromosome is the structure, the hereditary genetic material that passes on from one generation to the next. So a chromosome is like a recipe book. It contains many recipes. A gene is like a recipe. So a gene is basically a prescription that you should make, say, brown hair. You should make, blue eyes or brown eyes. You should make, the bone of certain size. You should make heart. You should make lung. It's a recipe that tells the developing organism how it should make and what it should make. So that's a gene. Well, a mutation, as you've heard about, is an error in the recipe. Maybe they wrote salt instead of sugar, or they wrote water instead of cream. And because of the mutation, the final product ends up being different than planned because of some error in how the recipe was recorded and passed down from one generation to the next. That's what the recipe is. Well, ultimately, genes make things. Genes lead to the production of things, and one of those things is a protein. And receptors are proteins. Receptors may be, let me restate that. Receptors are protein, but receptors they have a particular role particularly in breast cancer, and providing tools for treatment. I wanted to give you an example of what a receptor. I have three plugs. You can see these plugs, right? They differ by shape. So if you think of a protein, proteins that serve as receptors are all different. It's almost like you have an outlet in the wall. One outlet takes one kind of plug, another outlet takes another kind of plug, a third outlet takes a different kind of plug. What you have is a situation where on the surface of the cell, there are proteins, in this case, proteins that are receptors, and each of those receptors are different. They're a place where plugs or proteins or something from outside the cell would attach to the surface of the cell to stimulate some downstream activity. So HER2 positive breast cancers are a particular type of receptor that has a particular configuration to which something attaches that leads to the cell to behave in a certain way. It's a long explanation, I know, but I'm getting there. So ordinarily in the cell, I'm going to tie this all together. You have two genes that tells the genes to make a certain number of copies of these HER2 receptors. Typically it's two genes, and the average cell has about 20,000 protein receptors on the surface that are HER2, specifically HER2. There's also genes for estrogen receptor. There are also genes for progesterone receptor. They're all different. But for HER2 positive breast cancers, there's this one problem that sometimes happens where there is gene amplification. It means the gene's not the tumor, the cell not doesn't only have 2 copies of the gene, it has 2.5 or 3 or 4 or 5 or 10
Too many.
copies of the gene. And so you like having a recipe book with the same recipe repeated a dozen times. If you cook everything in the recipe book, you're going to make that dish multiple times. In this case, as it relates to genes, to follow through with the analogy, when you have multiple genes and they're all telling a cell to make 20,000 copies of HER2, then what you end up with in reality is something like 1 million proteins of Herceptin, or rather of HER2 on the tumor cell, not 20,000. And so in gene amplification in HER2 positive breast cancers, what you have is a situation where there is an abnormal expression of the amount of HER2 protein on the surface of the cells. Instead of 20,000, it's often 2 million or some number, some huge number like that. And so anything that stimulates HER2 will cause a cell to be really overexcited. HER2 is a growth factor receptor. It drives growth. So anything that stimulates growth, if you have many copies of that receptor, is going to cause the cells to grow at a much faster rate than one that has only 20,000 receptors. Sorry for that long explanation, but hopefully you can get the analogy and it helps you understand how receptors differ and why HER2 is a particularly important one in breast cancer. The main 3 receptors in breast cancer are estrogen receptor, progesterone receptor, and HER2. So that's why I think it's important to know about, and that's what we're going to talk about for this next.
How common is HER2 positive breast cancer?
So all or many cells have HER2 on it, but for breast cancers that have an overexpression of HER2 the receptor, it makes up about 20% of cells of cancers. So about 20% of cancers, 1 out of 5, will be HER2 positive. Now, what that means is they have an overexpression of amount. Most breast cancer cells, like many cells, have HER2 receptors on the surface, but that subset of cancers that have an overexpression of it makes up about 20%.
How is HER2 positive breast cancer usually treated?
Well, we've talked about various treatments for breast cancer in the past. There are cancer treatments that target the estrogen receptor, for example. They're usually pills. There are ones that target cancer sort of in a generic way, like chemotherapy. But the current treatment for HER2 positive breast cancers are to treat them with specific drugs that target the HER2 receptor, and also combine that with chemotherapy. That's the usual approach. The studies have shown that it's more effective when the two are combined. Many years ago, before we had drugs that were specific for HER2 positive breast cancers, these cancers were very aggressive and they were very hard to treat because the treatments that we had available, which is only chemotherapy, weren't particularly effective or weren't as effective as they needed to be for the HER2 positive breast cancers. But in 2006, Herceptin became commercially available. And when it was added to chemotherapy, it revolutionized the treatment of these cancers. It converted them from the worst actors to some of the best actors because the treatments were targeted, specifically targeted the HER2 with an antibody called Herceptin. It's an antibody that attaches to the HER2 receptor, and combined with chemotherapy, it was able to eradicate disease, improve survival as well for people that are HER2 positive breast cancer. So it was really transformative.
Do you have to be HER2 positive to benefit from the anti-HER2 therapy?
So that's an interesting question. So what is HER2 positive? Well, HER2 positive means that you have overexpression of the gene or an excess amount of proteins. And we usually assess something that's positive or negative in 2 ways. We say it's gene amplified, meaning it has excess copies of gene, or gene non-amplified, only has 2 copies of gene. Or we consider it has a lot of our proteins. And we usually grade the proteins as 0, meaning it's a cell with no HER2 protein on the surface. 1, which is a normal amount. 2 is kind of equivocal or indeterminate, and 3 is positive. And so since 2006, when Herceptin came on the market, the guidance was that it was only appropriate for HER2 positive breast cancer. So that's either the gene amplified or the 3+ level of expression. And the other drugs that have come out since then, Perjeta and so forth, have all been focused on the patients with 3+ or gene amplified. But it's recently emerged that there actually is a new drug called HER2, which seems to have some activity, significant activity, in patients with HER2 1+ and HER2 2+. Those patients would historically have been considered, I mean, even today, we generally consider them HER2 negative. But we now know that this drug can actually work quite effectively on those that have a normal amount or a slightly elevated amount, a non-amplified amount of the protein. So it's changing. It's changing. So as we speak.
Would those patients be like hormone positive or triple negative, maybe?
Well, triple negative, if you say triple negative, saying they're HER2 negative. And so, and historically, we would say that they were 1+ or 0 or 2. Maybe they aren't now. Maybe the triple negative patient who has a 2+ HER2 or a 1+ HER2 might someday benefit from this therapy. Now, that study hasn't been performed to my knowledge, but it's a provocative question because we've generally considered patients with triple negative breast cancer, which we're going to talk about in our next webinar, as people that weren't a candidate for Herceptin, and HER2 targeted therapy, aren't a candidate for estrogen or progesterone targeted therapy. But with this new data that HER2 might have activity in patients with 1+ or 2+ level of expression,
Might
just
make a
maybe,
difference.
maybe.
Is the body that produces the HER, is it the body that produces the HER2, or is it the cancer, or does the cancer make it worse?
Well, the HER2 is produced by the body, by the cell. It's a normal protein that drives growth in the natural growth of a cell. So it's just that when that gene is amplified in a breast cancer, sometimes it might be colon cancer because the genes can be amplified in other types of cancers, then it becomes a major driver for the growth and spread of that cancer. So it's not that the cancer is producing the HER2, the body produces the HER2 as an error in its replication, and it makes, instead of having just 2 copies of the gene, it ends up with a 3rd or 4th or 5th or whatever copy of the gene, and makes more of the protein. So it's an error in our cell function. It's not a cancer-induced process.
Is anti-HER2 treatment usually initiated before or after surgery?
Well, the answer depends largely on the stage of breast cancer. For the earliest stage, breast cancer, stage 1, treatments may be initiated, the anti-HER2 treatment may be initiated after surgery. But for the most part, since most patients with HER2 positive breast cancers present with larger tumors, and many of them present with positive nodes, we tend to want to treat them with preoperative chemotherapy and preoperative anti-HER2 therapy. We're going to talk about why that is so in the course of the discussion, but the standard of care is if someone has a larger tumor or a positive node, that they should receive, if they're going to practice according to standard treatment, they should receive preoperative treatment, drug therapy first, followed by surgery. There are a couple of really important reasons why that is so. Number one, by giving drug treatment up front, you get to see how the tumor responds to the treatment. And secondly, if the tumor responds only partially, leaving some living tumor in the breast or in the lymph node, it's a signal or a cue that the treatment, though beneficial, was incomplete. And it allows you to add another drug to get a better response. And so we actually use it to kind of determine, let me just say, there's also the reverse is also true, that if you get a great response initially, where there's no residual disease, you can make a decision that you may not need to add certain other drugs. So We use the time of the treatment, giving chemotherapy first, followed by surgery, to determine if we should escalate the treatment, meaning increase the intensity of treatment by adding more drugs, or de-escalate the treatment by not adding more drugs if the patient responds well.
So you're saying chemotherapy, what about anti-HER2 therapy?
Well, it is partially both.
Okay.
Yes, so they get in the preoperative treatment, they get chemotherapy. So generally speaking, the chemotherapy is given in this setting.
Without the anti-HER2 therapy.
They do both.
Okay.
So it's so the usual approach is for someone with a diagnosis of HER2-positive breast cancer, for them to get chemotherapy up front and anti-HER2 therapy up front combined.
Okay.
They receive them both. And then they have surgery, typically, for these patients. They
Or
get chemotherapy
cryoablation.
first. Well, we'll come to that.
Okay.
So they have surgery, and then after surgery, they continue on with anti-HER2 therapy alone for some duration, which we'll talk about. But if they respond really well to the chemotherapy and don't have any disease left, that tells you it's a good responding patient, good responding tumor, and maybe you don't need to add more therapy on the back end. However, if it responds only partially and you're concerned that there might be surviving cells, it gives you the opportunity to add additional chemotherapy, for example, or add additional anti-HER2 therapy to intensify the treatment further. So that's why there are some advantages, clearly, in pre-treating HER2-positive tumors with drug therapy first.
When HER2-positive breast cancer spreads, where does it usually go?
Well, as a breast cancer, it tends to go where breast cancers mostly go, to bone, to liver, to lung.
Wow.
But HER2 positives are particularly sneaky, and one problem is that they tend to go to the brain more often than the average breast cancer. So that's always a cause of concern because as they get larger, they can spread. They have a tendency to go, to distant areas, brain being one, and it's very hard to get drugs into the brain. So it tends to get, it's a blood-brain barrier. It tends to prevent a lot of drugs from having an effect there. So that's why it's really, a problem if these tumors are allowed to get large, because they can spread to places that are hard to reach with drugs. Even though the drugs make work great in the breast or in other body parts, they just don't penetrate the brain to the same level to produce or control or prevent recurrences as well as we'd like.
So are smaller ones less likely to spread?
Yeah,
Is there a correlation?
There's a correlation. Smaller ones are less likely to be node positive. They're less likely to spread. And so, as with any cancer diagnosis, there's value in being diagnosed early, because just statistically speaking, the less time it's in the body, the less time it has a chance to spread. But many of these, because of their rate of growth, are already a little bit, stage 1 and later stage 1 and early stage 2 or more when they're diagnosed, because they tend to grow a little bit faster.
Why is chemotherapy usually needed for HER2-positive breast cancer?
Well, the main answer to that question is that it was found to be more effective. There were studies looking at using chemotherapy alone, chemotherapy with the anti-HER2 therapy, which are basically, we call it targeted therapy, or treatments where you only use the anti-HER2 therapy and no chemotherapy. So it's chemotherapy alone, chemotherapy combined with anti-HER2 therapy and anti-HER2 therapy. And the best results were seen when the two were combined, when chemotherapy were combined with anti-HER2 therapy. That combined approach was superior to chemotherapy alone and to HER2 therapy alone. So it's just based on the results of clinical trials that if your goal is to get the best result and you have the liberty to add chemotherapy, the patients is willing to have chemotherapy, then that is the best combination that one can receive.
What is PCR and why is it important?
PCR is pathological complete response. Pathological complete response. It's a definition that is used to assess how well a pretreatment, like a pretreatment drug or pretreatment like chemotherapy or anti-HER2 therapy, works on a tumor before the patient has surgery. So the typical scenario is that the patient has been diagnosed with breast cancer. We give medications, chemotherapy, anti-HER2 therapy, or both combined, and then the patient goes to surgery to remove the tumor site. If there's no residual cancer left, like if the drugs have completely killed the cancer, leaving no residual cancer left in the breast or in the lymph nodes, that would be considered a pathological complete response. Now, there actually is another definition there. There's a clinical complete response, which means that the tumor that you could see on the mammogram ultrasound is no longer visible. So it looks like it's gone. That's called the clinical complete response. But the pathological complete response is when you take out that area of the breast, you look at it in the microscope, and you prove that there's no actual disease left. And so, the gold standard, the ideal that we're trying to get when we pre-treat a patient with drugs is to completely eradicate their tumor. That is the best result that one can possibly get. What is really great is that, the combination of chemotherapy and anti-HER2 therapy, particularly when 2 anti-HER2 therapy drugs are combined with chemotherapy, the pathological complete response rates for patients with hormone receptor negative breast cancer, but HER2 positive, so HER2 positive, hormone receptor negative, is as high as 80%. It means that 8 out of 10 patients, when given that drug combination before surgery, at the time of surgery, will have no disease left in the breast lymph nodes, completely clear. Regardless of size, whether it's 1 centimeter, 2 centimeters, 4 centimeters, positive nodes, it's remarkable that drug combination has worked so well. For people with hormone receptor positive, HER2 positive, so we call them triple positive patients, the numbers aren't as good, but they're still as high as 50%. And half of those patients will have no measurable disease left at the time of surgery. So it's really, again, what's trying to transform how we can manage those patients, and really has shown the capacity of targeted therapy to improve drug response. Now, if a patient simply went to surgery before having drug therapy, you wouldn't really get to know if they have such a responsive tumor. So giving the treatment up front does allow you to gauge how dramatically the patient respond. And if she's in the non-responder category, those that responded, but they still have some residual disease left, we now know that you can add additional therapy on the back end to kind of improve the results of those patients, outcomes of those patients.
Why is anti-HER2 therapy commonly given before surgery? Well, I can pretty much explain that.
Well, I think that's the answer, because we're trying to determine, and this will be, we're on the cusp of actually not on the cusp, we're actually utilizing this now in practice, but it's sort of a new frontier that, this escalation, de-escalation question, by pre-treating tumors, we can know whether or not we need to do more or less later. And if you have, if you didn't have any more to add later, then it would matter.
Mm-hmm.
But there's increasingly, new drugs or agents on the market that can be given as a secondary treatment for those who may not respond as well as expected to the standard course of therapy.
Do you recommend any treatment, chemo, Herceptin, for microinvasive cancer?
Well, what's interesting is that, traditionally we've recommended chemotherapy based upon tumor size and lymph node status. So if the tumor was over 2 centimeters or the patient had a positive node, that was the classic indication for chemotherapy. That was kind of where we started. And then we've sort of transitioned to that kind of genomics where the size doesn't matter. It's really kind of the genetics matter more. In this particular case, we know that even patients with small tumors that are HER2 positives, they have a high risk of recurrence. So the old rule of, say, 2 centimeters, give chemotherapy, don't really apply here. We actually treat for as little as 5 millimeters because we know that even small HER2 positive breast cancers can be bad actors. We have very effective therapies for them. So the threshold for treating a patient with HER2 positive breast cancer is much lower than it is for the typical cancer in terms of size, because of that reason.
Why do they still want to do surgery if the chemo HER2 drugs have cleared the cancer?
Well, we talked about clinical complete response. So that's just an impression. Like, you look good, but I'm not sure if, if we're going to work out. You have to have kind of experience to know at the microscopic level whether or not the cancer was eradicated. So the current standard is to remove that site. Now, you don't have to remove, if the tumor was 5 centimeters, you don't have to remove 5 centimeters of tissue. To get to that answer, we remove kind of 1 or 2 centimeters of tissue to see if the area that was previously positive, whether it was cancer person before, has no cancer remaining. Now, the assumption is that those patients will go on to radiotherapy, so they'll get some additional breast treatment. But the current standard of care after chemotherapy, even when there's a clinical response, everything looks clear, is to make sure that there's a pathological response that's complete. That is, we need to remove tissue to look at it under the microscope to see if there's residual disease. There may in fact be no more invasive cancer, which is really what we're trying to treat with chemotherapy, but there could be ductal carcinoma in situ, which is non-invasive breast cancer. No one dies from DCES, but DCES can be the source of future invasive cancer. And so that area needs to be managed surgically or by some means. And so that's why it's important to know if there's residual DCES. Even if the invasive cancer was completely clear, which would be considered a success, the presence of residual DCES could be a problem long-term in terms of recurrence. So that's
And a
why
biopsy is not enough.
a biopsy, the study was done. There was a study done where they took patients that had pretreatment with anti-HER2 therapy, chemo, look at those that had a clinical complete response. There was no visible tumor left. They then did multiple biopsies of the area, and then they did a lumpectomy to see if the biopsy sort of replaced the need for lumpectomy. And they find that there was sufficient patients with disease outside of the biopsy site that with disease outside the biopsy site that at this point still necessitates a more comprehensive treatment. Comprehensive meaning a lumpectomy, maybe ablation in this case, as we talk about, and whole breast radiotherapy to treat that area. So we're not at the point of doing nothing more for those complete responders because DCES is still a little bit of a challenge, and DCES does not clear with chemotherapy. It's not active enough to be killed with chemotherapy. So it's not like you can, a great response from clinically will mean that there's no residual DCES. It still has to be managed.
What are your thoughts on Herceptin for 6 months versus a year?
Well, I think it's a excuse me, it's a question that's evolving. There have been studies looking at 6 versus 12 months at Herceptin, and the results have been fairly comparable. That's my understanding. But I think that if it kind of depends upon how you respond. If you got pre-treatment with chemotherapy and you responded well and you had little disease left, that's a situation where you might consider de-escalating, giving 6 months versus 12. The standard has always been 12. The first studies that looked at Herceptin utilized Herceptin for a year. So that was a gold standard, and it still is a gold standard. But now that we have a more nuanced approach to treatment, if you get pre-treatment like preoperative chemotherapy with Herceptin and have no disease left, that's a situation where you have a PCR where you can argue that you might not need as much anti-HER2 therapy. On the other hand, if you have residual disease, it implies that you may need a longer course. So the 12-month course. So I think that the decision is made on an individual patient based upon their risks.
Well, yeah, the other risk you have is the heart trouble you can get from it.
Yes, the longer course was associated with there were comparisons between 12 and 6 months. The 12 months had more cardiac toxicity. 6 months had less. 12 months actually was a little bit more effective. It's just that it wasn't dramatically more effective, but it's a little bit more effective. So if you don't have cardiac toxicity and you're able to take it for a longer period of time, especially if you have high-risk disease, it makes sense to continue it because it does have some additional cancer control benefits. But if for some reason, you cannot continue to take it because perhaps you have some pre-existing or drug-induced cardiac event, 6 weeks seems to be a good
6 months.
6 months. So 6 months seems to be, thank you for that. 6 months seems to be a good course of therapy without too much loss and effectiveness.
So you just have to really evaluate where you are and who you are and what you've got.
Right. You have to weigh.
It's individual.
It definitely is individual. You have to weigh, the extent of disease that you started with, the extent of disease that you ended up with after pre-treatment, if you got new preoperative chemotherapy, and your baseline risks. If you have cardiac disease, at the beginning. And of course, during the course of therapy, the cardiac functions are monitored by
every 3
oncologists.
months.
Exactly. So, the goal is to detect any decline in heart function and to adjust the course of treatment so that they're not causing persistent injury to the heart. The reason why the heart actually is potentially injured is that myocardial cells, heart cells, express the HER2 protein. It is part of their normal function, and so a drug that targets or impairs HER2 can also affect the heart. So, it's kind of one of the organs that limits the dose you can give, because if you give too much, it can hurt the heart. But the science has sort of found the right dose so that you can kill the cancer without hurting the heart. That's the idea. And they just have to monitor the heart to make sure that they're correct in their calculations.
I know of some trials using neoadjuvant Herceptin Perjeta without chemo. Would you be willing to share your thoughts on the results of these trials? When, if at all, do you see this becoming first line of treatment for early HER2?
So I mentioned earlier that there was a trial. This trial, I think, was called the Trifina trial, that looked at chemotherapy alone, chemotherapy plus 2 anti-HER2 drugs, and 2 anti-HER2 drugs alone. So 3 arms. The third arm was just antibodies alone. I may have not mentioned it. I think I mentioned it before, but the actual drugs against the HER2 receptor are antibodies.
Right.
They're antibodies that attack or that attach to the
monoclonal antibodies.
Monoclonal antibodies, exactly. And so when I say antibodies, I'm referring to Herceptin or Perjeta or the combination of the two. But in this study, they treated patients before surgery with chemotherapy alone, chemo plus antibodies, or antibodies alone. And they found that the highest PCR rates was in the group that received both. But there were about 20% of patients in the anti-HER2 antibody arm that had a pathological complete response. So it did work for some. It just wasn't as good as combining it. So I think, we're not at the point now of using the currently available drugs as a standard treatment. But I know I just recently learned from one of my oncologists that there is a current trial that's ongoing that's looking at a similar kind of combination. And one of the arms of the trials just has, Herceptin and one of the newer, a second anti-HER2 drug that's called in HER2. So it's a Herceptin in HER2 arm. So it doesn't have Perjeta, which is one of the antibodies, but it might just be the right combination of anti-HER2 drugs that could do the trick. We don't know. Clearly, all the evidence says chemotherapy combined with anti-HER2 therapy works best. But for those that are unwilling to have chemotherapy or who may have toxicity related to chemotherapy, there will, I think, at some point be a way to treat them with just the antibodies alone with sufficient control, so that it becomes one of the standard tools that we use to treat breast cancer.
What are your thoughts on stage 4 de novo HER2 patients who achieve pathological complete response coming off a maintenance treatment?
So it's a little complicated question, but I'll explain a few things about it.
Okay.
So stage 4 means that they have cancer that has metastasized beyond the breast and lymph node area. De novo means that DENOVO means that the diagnosis of stage 4 breast cancer was made at the initial diagnosis of cancer. So they came in, they had a lump of lymph nodes, whatever, they were worked up, they were scanned, and were found to have a liver metastasis. So the distant metastasis was present at the point of diagnosis. And so those patients would then go on to treatment. We would treat them as stage 4 patients. See the question once again. I want to make sure I got the last part.
Maintenance.
Right. So when someone has stage 4 breast cancer, whether it's her stage 4 HER2 positive breast cancer, whether it's de novo or they develop a metastasis later, maintenance therapy is the standard of care. That is, they go on, we recommend a 3-drug combination, Herceptin typically with Perjeta, and docetaxel, which is a chemotherapy agent. So chemotherapy plus 2 antibodies. That is the standard treatment, first line, for patients whether de novo or have secondary HER2 positive breast
Mhm.
cancer, stage 4. And that treatment is continued indefinitely. There is some discussion, when is it safe to stop? There's no clear answer to that. But if they have complete control of disease, no evidence of additional tumor growth or spread, it makes sense to continue it for as long as it continues to work. And it could be years.
Do you believe maintenance treatment should be done for a certain period of time following PCR? Well, you just answered that.
Well, it's a similar question, but not exactly the same question, because in one example, in the first question you asked, we have a patient who was diagnosed with breast cancer. She has disease. And so many stage 4 patients never get to surgery. We just kind of treat their stage 4 disease with drugs. They're not surgically curable, so we don't necessarily do surgery unless, you could do it, but doesn't determine their prognosis. Their prognosis is determined by whether or not you can control the tumor in the liver or tumor in the bone or whatever. But there's another question, which is that, if you have a patient who doesn't have stage 4 disease, she has curable disease, she gets pretreatment with anti-HER2 therapy and chemotherapy, and she has a PCR, how long do you continue therapy after that? So I kind of addressed it earlier.
Okay.
Do you do 6 months? Do you do 12 months? I think currently the standard is still to do 12 months, but at some point we might decide that we can treat less. In fact, there was one study that looked at treating as little as 9 weeks and found that was pretty good. It wasn't as good as a year, but it wasn't markedly inferior.
Do they still do it every 3 weeks or do they do it more often?
I don't know the regimen, but the point was the total duration was less.
Yeah.
And so I think it's evolving. It'll change. But again, it'll largely depend upon how much you start with, how well you respond to what's given. If you're a PCR, that will, I think, open up some opportunities to de-escalate the therapy a lot more, to treat less aggressively, less intensively.
In the first year, is the first year most detrimental and likely to grow? If you're cancer-free for 2 years post-treatment, does that mean the chance of reoccurrence is significantly less?
Well, there's this pattern of tumor recurrence. I'll just reframe the question. That when tumors, when a person is diagnosed, kind of a new clock starts to tick in a sense. That we start to look at their survival from that point onward. And there is, we will treat them with all the standard therapy. We'll do surgery, we'll do lumpectomy, mastectomy, we'll do chemotherapy, we'll do radiation, and then we'll follow them over a period of time, with the hope that we've killed off every cell that remains. But if there were some surviving cells in anywhere within the body, there's a pattern of recurrence that tends to emerge where at about the 2 to 3 year time point, you begin to see those recurrences. That's because it takes that long for tumor cells that is not visible by a mammogram, ultrasound, MRI, and all those other studies. It takes that long before it becomes detectable, before it becomes a 1 centimeter lesion or 2 centimeter lesion. So, when we finish treatment, we try to give the best treatment regimen we can with the hope that we've cleared away everything. Fortunately, now there are medications like for patients with ER positive tumors that you can keep them on for 5 years or more to kind of keep the brake on any tumors that have been left behind. But for those for which there isn't a maintenance therapy, the time point in which recurrence risk is highest is in the second or third year. So we must kind of keep our antennas up to make sure that we can recognize early recurrences. It's just left behind disease that wasn't killed off, that had a chance to grow.
So if you pass the third year, are you somewhat safe that you?
Well, it tapers off. You don't go from once you have 30 to zero risk of recurrence, but it tends to become a little less likely as a year's pass.
And that starts at the third year?
It sort of you start to see the recurrences in the second year.
Okay.
They peak in the third year. There's still a good amount in the fourth year. There's less in the fifth year. There's less in the 6 years. That's the pattern. And it's true for cancers in general. The more aggressive cancers, that peak will be a little bit earlier. The less aggressive cancers, that peak will be a little later. maybe 5 to 7 years for an estrogen receptor positive cancer that doesn't have HER2 expression, for example.
I'm I'm ERPR negative, HER2 positive, and I'm having a very hard time finding information on this type. Any information on how or what to do with a very large 9-centimeter tumor? They want to shrink it before surgery. I want to do it as naturally as possible.
So that's an
PR negative,
PR negative,
HER2 positive.
right. So we call it hormone receptor negative, HER2
Right.
positive. So that's an example of the type of tumor that I described earlier. The one that we recognize in the Trifina trial was remarkably responsive to the right chemotherapy regimen. I understand why they're recommending preoperative chemotherapy. She has a 9-centimeter tumor. Very hard to do a lumpectomy on that. It requires a mastectomy. Furthermore, there's a reasonable concern that she may have positive nodes. So there's a surgical question. The burden of disease is great. She likely need to have a mastectomy and all of her nodes removed because of the burden of disease. But more importantly, there's this question of her survival. And she needs a drug therapy that's really effective to deal with not the stuff she's looking at in her breast, but the stuff that might have already metastasized. So this drug combination, typically referred to as TCHP, HP, Herceptin, Perjeta, and then TC2 chemotherapy drugs. So it's a chemotherapy drug and 2 anti-HER2 drug combination. That drug combination is the one that achieved the 80% pathological complete response rate in that trial. It's a remarkably effective combination of therapy, chemotherapy and antibodies. I would strongly encourage her to consider that. That 9-centimeter tumor might completely disappear after that. They may take the surgery. She could potentially be a candidate for lumpectomy. They may not need to remove many lymph nodes as a result of it. And of course, if she has disease outside of the breast or lymph node area, it's likely to respond in the same way. So it really is truly a life-saving course of therapy. And I hope she's open. I think the problem with the natural way of doing it is that there's no evidence that the natural way works. And she's at the point where she has a locally advanced tumor that would do some very bad things. There's a window of opportunity to treat it very effectively. Bad things being ulcerate, spread, and so forth. So I would hope that she would utilize the standard therapy to deal with the known cancer, and then use, if she's concerned about the impact of chemotherapy on her long term, I would say you should focus on using naturopathic ways to manage those. If you believe in naturopathic medicine, I hope that you believe in its ability to also correct problems that may come about from standard treatment. But we have here a really effective drug therapy regimen that might work miraculously for a tumor, and I wouldn't want her to deprive herself of that opportunity.
Is PCR residual cancer burden the key indicator for reoccurrence risk, or are they both other factors, age, node, stage, grade, and how are they weighted?
So I can't answer every aspect of that question, but the key thing is that the PCR, the pathological complete response, is the most important index for response, which is why our bias is to pre-treat the patient with drugs, meaning give it prior to surgery, so that we can gauge how well the response is. If we determine that she is a great responder, they've achieved a PCR, there's no residual disease left, then, as I said, obviously you can hope because it worked well, you get confidence that the treatment worked well, and we're increasingly at the point of deciding that we don't have to do as much therapy after. If they don't have a PCR, it doesn't mean that their prognosis is bad, but it just means that we just may need to do more. So the PCR is the one that matters most. Stage, age, those things are important, but they don't drive the treatment decision for this type of breast cancer.
Can HER2 be a genetic cancer? If it's genetic, they haven't figured out what the marker is to test for. I did a highest level genetic screening and it was negative for all cancer markers. Is there a possibility they just haven't figured out what the genetic marker is?
So some breast cancers are hereditary, others are not. By hereditary, it means that you have a damage, a defective gene, your recipe, and that when it's passed on from one generation to the next, that recipe and its damage
Right.
and its defects are passed on as well. BRCA mutation is one type of hereditary breast cancer. It's one that may be passed from one generation to the next. HER2 is not a link to a genetic mutation. It's not something that tends to manifest along with BRCA positive or PALB2 positive or ATM positive breast cancers. It is more of a feature of the cell that and how it develops in an individual. It's not hereditary. So if you've been diagnosed with HER2 positive breast cancer, it doesn't mean that your daughter has an increased chance of having HER2 positive breast cancer if she develops breast cancer. That's not how it works. It's simply kind of a random effect.
So my 3 daughters don't have to worry about it. They just have to worry about the other kinds.
They have to worry about breast cancer.
In
Of course, they
general,
should be
but-
screened. But if they were to get breast cancer, there's nothing to indicate that their breast cancer is more likely to be HER2 positive. More than likely, they would have a breast cancer that you typically see in their age group or based on other risk factors. Most of them will be HER2 negative. Most of them will be hormone receptor positive, or maybe triple negative. But your HER2 positives doesn't mean that a sibling would be likely to have HER2 positive.
You just mentioned age factors. Is HER2 more common in older women, or is it just kind of across the board?
It's more common in younger women.
Oh,
But we
wow.
do see older women with HER2
Well,
positive
obviously.
breast cancer. But it is more common in younger women, yes.
Interesting. HER2 enriched in lobula is very rare. Lobula is a slow growing, but HER2 isn't. So this combination is rare, and which is the major factor in the better outcomes?
So there are different types of breast cancer. There's ductal type, in like invasive ductal breast cancer. And there is invasive lobular breast cancer. Those are the two major types. There are other types as well. We call the other types special types. But there's some patterns that we tend to see. Invasive lobular breast cancers, biologically, for the most part, tend to be a non-aggressive sort. They tend to be very strongly expressing estrogen receptor. They tend to be rich in progesterone receptors, and they're almost always HER2 negative, either 0 or 1+. So there is, it's in most cases for someone with a invasive lobular cancer, you wouldn't expect that they would ever need to have Herceptin therapy or anti-HER2 therapy. But there are some situations in which they may be HER2 positives. And so that's why it's important to test the biomarkers. As a surgeon, we don't really make a decision about surgery until we see the receptors. Certainly we did in the past, but now that we know that the receptors matter as much as they do, we have to look at the receptors before we can make a definitive decision about what to do surgery. Is surgery the right first treatment, or is chemotherapy or anti-HER2 therapy the right first treatment? That also applies to lobular. Now, whenever I see a HER2 positive lobular, I want to let's recheck to make sure this is cool, because this is a kind of a weird combination. It's an uncommon combination, but it is certainly possible. But most lobulars are traditionally, HER2 0 or 1+, not 3+. Most are not amplified. When they are amplified, they have to be managed as HER2 positive breast cancer. It doesn't matter if, from a chemotherapy perspective, if they're lobular or ductal. Now, the one additional comment that I would make is that, ductal cancers, when they respond to chemotherapy, tend to have a more concentric response, meaning if it's this big when it starts, it tends to shrink like that. And so it becomes a smaller area to remove if you're going to do surgery. Lobular cancers spread kind of as individual cells. So they kind of disperse out over a broader area. So you have a cell here, you have a cell here, you have a cell here, have a cell here, here, and here. And so they may shrink, the bulk may be less, but the total span doesn't necessarily, because they're not really holding on to each other. They're individual cells that are separated. And so although the density of the problem may be less, the lump becomes less thick, the actual area where the cells exist might not change dramatically. So even though you might get a great clinical response and that would be good for your long-term survival as well, to predict your long-term survival, surgically, it might not change what has to be done. You might still need to have a large area of tissue removed or treated because lobulas tend not to shrink in that way.
HER2 breast cancer spread to the brain. What is the best treatment for it?
Yeah, so as I mentioned, HER2 positive breast cancers and have a tendency to respond to metastasized, especially for stage, for people with advanced stage disease, either stage 4 disease that is not well controlled. As it continues to grow and spread, then the brain is one place where the disease often manifests itself. And it becomes a bit of a challenge to treat because the drug therapy doesn't really work as well there. So usually the treatment focuses on using surgery. If they have a solitary or single lesion, to use surgery to remove that lesion. Or if they have, I think it's up to 4 different lesions, you can use targeted radiation to treat those areas. And for those that may have more, you can use whole breast radiation to treat it.
You mean head?
Whole brain, whole head, whole brain radiation to treat the area. Sorry, whole brain radiation to treat the area. So it's either surgery if it's solitary and they can get to it safely, radiation if it's a few lesions, or whole brain radiation if it's multiple areas. And of course, you still need to continue the anti-HER2 therapy for the areas you can treat and can control outside of the brain. But it's primarily a surgical radiation approach to managing brain metastasis.
I would like more clarity on the risk of reoccurrence for triple positive. I have 2 oncologists that tell me the risk of reoccurrence will go way down after 2 years because of the HER2. But I had another oncologist tell me that it's not true because mine is also estrogen driven and risk is higher further out than that.
So we talked about the 3 receptors. I might have gotten mixed, but ER, PR, and HER2. The most important one is the HER2 receptor in terms of protecting tumor behavior. And so we have to prioritize therapy that targets that receptor, the anti-HER2 therapy. But anti-HER2 therapy extends at most for a year after your primary diagnosis for patients with early stage of breast cancer. So there's no maintenance therapy that we use beyond a year for HER2 positive breast cancer patients. Now, for those HER2 positive breast cancers that have estrogen receptor positive and progesterone receptor positive expression, they still need a treatment that targets that part of the cancer. It's actually, in some way a good thing because we do have drugs that target those. And so, we need to utilize tamoxifen or one of the aromatase inhibitors to target the hormone receptor part. And for that reason, there's not only a need to treat for a longer period of time, but if they're untreated, there's a longer risk of recurrence. The HER2 positive hormone receptor negatives don't have a maintenance therapy for the estrogen receptor part. So if they're going to recur, they're going to recur pretty quickly because there's no other way to control it. They're more likely to occur in that 2 to 3 year period. But the HER2 positives that have a hormone receptor component, the hormone receptor positive component, they have a longer horizon for recurrence. They have a longer horizon for treatment because we can give the anti-estrogen therapy 4 or 5 years or more. But once that therapy comes off, because eventually we stop, if there are some surviving cells, they may begin to merge later. So there is truth to the ER positive, the triple positives having a longer horizon for recurrence than the hormone receptor positive, hormone receptor negatives.
I know of some trials using neoadjuvant Herceptin Perjeta without chemo. Will you be willing to share your thoughts on the results of these trials? Also, then, when will, if at all, do you see this becoming the first line of treatment for early HER2 positive?
I think I might have answered that question partially earlier, but there is an ongoing trial, as I mentioned, that is utilizing just the antibodies alone. It's a randomized trial, so the patient can't say, just give me that arm. They have to be willing to take the
Right,
chemotherapy and
whichever.
antibody arm. But it is, I think it will be, if it's positive, if it proves to be effective, it's going to open a new pathway for treating patients. I certainly have a lot of patients that come to me refusing chemotherapy. And so I try to encourage them to at least consider taking the antibodies and refer them to oncologists who may be open to treating them with antibodies alone. Not all of them are, but
Mhm.
we know that, at the very least, antibodies are better than doing nothing. And the better the antibodies get, the better they'll be able to control the disease. And so this ongoing trial is using newer antibodies for the HER2 receptor, and it might prove to be even more effective or similarly effective to chemotherapy.
Okay, I don't know if you know the answer to this, but I just recently did a talk on monoclonal antibodies, and they were talking about some new drugs that might be coming out with the anti-HER2 therapy and one molecule of chemo. What does it mean by one molecule?
Yeah, well, I think what
Is that not as strong, is not as, not effective isn't the word I want. Is that not cause issues with the body as much as the ones that are out now?
right. I'm not sure if the one molecule versus more is the key thing there. I think we've traditionally talked about antibodies and we talked about chemotherapy as two separate things. You give chemotherapy, you give the antibody, or you give them together.
Together.
But there's a new category of drugs that have been created where they've actually taken an antibody and bound it to a chemotherapy drug. So it's almost like the chemotherapy is like a Trojan horse kind of scenario.
Exactly, that's what I heard.
The antibody attaches to the HER2 positive
Right.
cell, and it has chemotherapy linked to it so that the chemotherapy can get to the cell more effectively.
Yeah, the way it was explained in the thing I listened to was that the Herceptin attached to the cell, and then it got the chemo inside and the chemo burst the cell.
Yes,
That's how it was explained.
exactly.
in the-
So it's very much
But I
like
was
a
just trying to
Trojan
figure out
horse.
what they meant by a single, one molecule. I didn't know if that had any significance or not.
Well, the more drugs you add, the more chemotherapy drugs, the more the toxicity. So if you can get greater toxicity with fewer chemotherapy drugs, with one drug as opposed to multiple drugs, then that'd be better than utilizing multiple. So I think the idea is simply to kind of, use one drug, but to get it to where it needs to be more effectively. In that using the antibody as a Trojan horse helps that process. The two drugs that fall into this category, people may have heard of, is Kadcyla and HER2. There are two antibody drug conjugates where there's a
Oh, they do have a
chemotherapy,
chemo in them? I didn't know.
chemotherapy and an antibody combined, which is a more effective combination.
If you do one of those, can you, and it shows that it had an immediate response, can you do it for a shorter amount of period? I'm just asking because I know somebody who only did a couple of them and it was gone and they're not doing it anymore.
Well, there's evidence-based approaches, and there are some that are not evidence-based. I don't think that's evidence-based, but the trials are ongoing. We don't have the final answer yet.
So it's not known yet anyways.
Yes, but there's a lot of reason for hope. We have some early indications that it's a very effective combination, but the assumption is you receive this course of therapy as prescribed, and so when people deviate, you can't really assume that someone gets only a portion of the entire course would do as well as someone who gets the entire recommended course. The trials weren't based on that.
Okay. Are the considerations for doing cryoablation different in HER2 plus positive beyond the fact that they typically present with larger tumors and lymph involvement?
Yeah, so I want to focus on one aspect of that question, which is, the timing of treatment and how you prepare for the patient. So I see lots of people with HER2 positive breast cancer diagnosis, and they come to me for cryoablation. Many of them come with the hope that they can avoid chemotherapy, but I try to get them correct very quickly that for this kind of cancer, the risk of growth and spread is so high that chemotherapy is crucial. But if they were to let me guide them along the way, what I would tell them is, let's do appropriate imaging to assess the extent of disease that you have. So I would do mammogram, ultrasound, MRI, whatever, get a good idea of the disease. I might ask to add some additional markers so I can see, the left and the right edge more clearly, like place some marker in the breast so that I know where the disease was. But I would tell them to go with anti-HER2 therapy first. I'm going to explain why the markers matter in a moment, but I would tell them to go with the anti-HER2 therapy first because we need to know, it would benefit her to know whether or not she's a responding patient or a non-responding patient. So if she's willing to have chemotherapy and she's willing to have anti-HER2 therapy, then the best approach would be to start with that combined therapy first. And then after she's done, if she still desires to have cryoablation, we would then offer her the treatment. At the time of the treatment, we biopsy the site to see if there's any residual disease left. If there's residual disease, and that information will be used by her oncologist to determine what more she should receive.
Explain the word you just used, bobsled.
Biopsy.
Yeah. Oh, biopsy.
Yeah, we would
Okay.
do a
You said
core
it so
bi-
fast. It
yeah,
sounds.
I'm sorry.
I didn't pick up on the word. Okay.
We would do a core biopsy of the original tumor site to determine if there's any residual tumor cells left at that location, because we want to know if there's residual disease. If there's no residual disease, that would be an indication that she likely had a pathological complete response. And maybe it's a situation where we de-escalate therapy. If she has residual disease, it would mean that she would likely benefit from additional therapy, and we would recommend escalating therapy. But that information about the response and what you need to do next is really crucial. So if they're willing to have chemotherapy, it's best to do the chemotherapy first. Now, the challenge with cryoablation is that cryoablation is most effective when you have a clear target. So, and as you get chemotherapy, and as it disappears, the target disappears. There could still be disease present, like DCIS or small areas of invasion there. You want to be able to treat. The question is, how do you find the area to treat? So placing those markers in the right place, or at least knowing how the markers relate to the tumor, will allow us to at least have a target. And my belief is that if you're going to treat a patient post chemotherapy, like someone who's had pre-treatment chemotherapy, that you should treat the original tumor volume. So if the tumor was 5 centimeters before and now it's down to 1 centimeter or it's completely gone, you should still assume that there are pieces of DCIS or something in that 5 centimeters area of tissue, and you should treat it as if the entire area. With surgery, I could take less, but the pathologist will look at the tissue in the lab and say, okay, your margins are clear. I don't think you have more behind. With cryoablation, we don't get the same information. We don't remove tissue to look at margins. They can remove tissue, but that tissue isn't amenable to margin analysis. So we have to assume that there's maybe some things that are beyond the area that was biopsied. That's why having the markers in the right place so that I can ablate the original volume helps me get back to what I want to treat. Now, on the other hand, I have patients who sometimes say, I'm absolutely not going to do anything drug-wise. I really, really, really try to get them to consider it for the reasons we've already talked about. But if they're completely unwilling to do it, then with drug therapy or chemotherapy, anti-HER2 therapy, then I feel morally, ethically bound to stop the process that's on the way, to offer them cryoablation to kill the tumor that is currently in their breast, because if I don't, it will likely grow and spread, and then there would have been a lost opportunity. But that's really not the wisest approach. The wisest approach would be to utilize the pre-treatment chemotherapy, ideally with the anti-HER2 therapy, followed by cryoablation if cryoablation is desired.
How does cryoablation compare with surgery in terms of reoccurrence risk? Have the studies been done for HER2 positive specifically? Along the same lines, how would you want to time cryoablation if someone is going to receive Herceptin or Perjeta, which kind of answered? Would they have a lower risk of reoccurrence if they'd had targeted therapy on board before the cryoablation?
So a few questions there. So let's start with the first one. So how does cryoablation compared to surgery? So there have been studies that looked at cryoablation. Those studies have not been randomized studies, so we don't have a head-to-head comparison. But they're prospective studies, meaning patients have had cryoablation of small breast lesions, node negative, stage 1. Most of the studies were patients with a HER2 new negative. They're hormone positive and HER2 negative. That's what the data addresses, that population of patients. Stage 1, node negative, hormone receptor positive, generally speaking, HER2 negative. Those studies show that for tumors 2 centimeters and smaller, the ability to control the site with cryoablation is as good as the ability to control the site with surgery. The local recurrence rate has been consistently 3% or less for patients treated with cryoablation of the tumor site compared to those undergoing lumpectomy. Now, those aren't randomized trials. We're just comparing the people that receive cryoablation alone to the historical results and the current results we're seeing with patients undergoing lumpectomy. There is a randomized controlled trial that is currently under development. I've been involved with one of the companies that makes the probes, and they have committed and set aside funds to do about a 2,000 patient study. We're going to randomize. Yes, it's nice. We're going to randomize patients, stage 1, node negative, meaning their nodes look normal, to either lumpectomy or cryoablation. So about 1,000 patients will be treated with cryoablation, about 1,000 patients will be treated with lumpectomy, randomized. We would not limit it by, at least the current idea is that we're not going to close the door to those with HER2 positive breast cancers. If they are a candidate for surgery up front, then they will be a candidate for this option. It won't be limited by that. That'll be the first data we'll have for HER2 positive.
Tumor size limit?
Stage 1, so 2 centimeters or smaller.
Oh, okay.
And node negative. And so we'll get to see how well cryoablation performs compared to lumpectomy. It doesn't have to be as good, it just needs to be close enough. But I think that HER2 positive breast cancer in of itself, the HER2 feature, does not make it ineligible for cryoablation. It's just a matter of making sure that you don't forget that the other parts of treatment are really important, and the timing of those other treatments are really important. And so the cryoablation should not be prioritized. Ideally, for a patient, if the patient again is unwilling to have chemotherapy, then cryoablation takes priority. But that's choosing the lesser solution. The better solution would be the drug therapy first. So I think I might have answered all those questions, or maybe not. But maybe we'll come back to it if I didn't.
Do you ever recommend pre-treatment with Herceptin and Perjeta to shrink the tumor prior to cryo? Do you trust the current state? Do you trust the current status or go back to the original? Well, you already answered this. Scans for determining the area.
Yes, it did. But it's important to emphasize again, because I sometimes, whether it's HER2 positive breast cancers or not, or triple negative, or even the hormone receptor positive HER2 negative breast cancer, I sometimes see patients that want to do additional therapy before they have cryoablation therapy. Now, sometimes, it's important to do preoperative chemotherapy, but at least from my perspective, if their goal is to give me a smaller target to cryoablate because maybe for different reasons, I think that often it's not a success. Well, so there's standard therapy where you do preoperative treatment to shrink to smaller size, and there's non-standard therapy. I think the data for standard therapy is a little bit more predictable. It's not perfect, but we know kind of what we can expect. For non-standard therapy, meaning the non-standard traditional chemotherapy, I think it's very difficult to predict how well the tumor will respond to pre-treatment because we don't really have studies showing it. So sometimes people want to do a lot more things with the hope that they will shrink it, and it doesn't really help. There may be shrinkage, but the original volume still has to be treated, number one. It's just that the original volume is just harder to find because of the pre-treatment, especially if I didn't have the opportunity to kind of map things out before they started. So I think unless you're participating in a standard protocol that calls for preoperative chemotherapy first, I think it is best to do the cryoablation before the treatment starts. But if you have HER2 positive breast cancer, which can be impacted, which can influence how you treat it after this escalation, de-escalation question, or triple negative breast cancer, which also has an escalation, de-escalation component, for those two, I think it's best to do the drug therapy first, followed by cryoablation.
I see lots of posts concerning aftercare. What type of testing is used after cryo, and how often is testing required? Lifestyle effects.
So, there's no standardized rule about how patients should be followed after cryoablation. Typically, for a patient with standard lumpectomy, we follow them on a yearly basis with mammograms. If they have dense breasts, we may add ultrasound as a standard study for annual follow-up. And in some situations, we may add MRI as their standard annual, in addition to mammography, as a standard annual study. For cryoablation, I think we'll probably end up with the same protocol. It's just that our experience with cryoablation is still relatively new. Our imaging experience is still relatively new. I think, at least at the beginning, we need a more intensive approach. My approach, my recommendation, is that patients undergo a set of imaging studies 6 months post-ablation. So they have cryoablation today, 6 months from now, they would have a mammogram, an ultrasound, and an MRI. It's a lot of studies, but I think what is clear is that no study is perfect at detecting imaging, even in a normal situation, but it's even more challenged by cryoablation where there's some distortion related to treatment. What we're trying to see is the development of new cancer or development of residual cancer by whatever means necessary. In most cases, when recurrences have happened, those recurrences have happened at the borders of the cryoablation zone, but sometimes they're hard to see. I use mammogram because maybe if that cancer is developing calcium deposits, then it will be detectable with calcium deposits. If it's a mass, ultrasound may demonstrate the mass feature. If it's MRI, or if it's an area where the blood flow is increased but it hasn't formed a mass, an MRI might be revealing. So we basically, tried to utilize those 3 studies and their ability to see different parts of the problem to detect the recurrence. However, recognizing that all of those studies still have limitations, no study can say there's 0 cancer present, we still recommend the biopsy. I still recommend the biopsy. So at 6 months, it's mammogram, ultrasound, MRI, and a biopsy. Going forward, if that study if the residual disease is found and the biopsy is negative, then I ask the patient to return to annual imaging with mammogram and ultrasound. They don't have to do ongoing MRIs unless the 6-month MRI shows something that needs to be followed up. But I think at this point, we're still trying to learn, and radiologists still trying to learn what to expect from mammograms, ultrasounds, and MRI in a post-cryoablation treated patient, and they need the experience. It also helps to have a biopsy done so that they can believe that the things that they see are actually the normal healing wound, not cancer, because most will interpret the post-mammogram, post-mammogram, post-ultrasound, and post-MRI studies as evidence that the tumor has grown because they once saw a small area that's now much larger. Fat necrosis can sometimes look like cancer. So doing a biopsy to confirm that those areas are benign will allay a lot of concern amongst radiologists and patients that the thing that they see on the mammogram or ultrasound MRI is actually just a healing wound.
If you reach NED and you're stage 4, what are your thoughts on surgery and radiation, like stereotactic radiation?
So NED, no evidence of disease, stage 4. So that's a scenario where the patient was diagnosed with HER2-positive breast cancer. I think this is the example we're talking about. They got treatment, and the area that was detected in the breast and in the liver, for example, disappeared. So they have no evidence of disease. Question is, what do you do? Do you just, stick with what you're doing? Do you deal with the tumor in the breast or tumor site in the breast? Do you deal with the tumor site in a distant part of the body? And for the most part, we would say if they're NED and they have truly no evidence of disease in any body part, and they should just stay on maintenance therapy and do nothing. Now, most people don't, unfortunately, most people don't get to that, but they can have stable disease. So if you have, an anti-HER2 therapy and the liver lesion isn't growing, or at least it's smaller, the breast tumor may be persistent. Maybe there's a persistent node. The question is, does the patient benefit from having the breast tumor removed, or the lymph node removed? And it's not clear that they benefit. That's still an ongoing debate. Some studies show benefit, some studies show no benefit. But if the treatment option that you have to manage that is low burden, like maybe ablating the breast tumor as opposed to taking the surgery to remove it, then there actually is sort of an opportunity to kind of minimize the burden of disease, eliminate the breast as a site of future recurrences, eliminate the lymph node as a site of future recurrences. Or if there's an area where there was previously disease in the bone that is now clear, maybe irradiating that. That's what the target radiation is about. So there's no rule about it, but it seems like, if you have a patient with a good prognosis and controllable disease, and your treatment option, and if at the same time you have some treatment options that are low risk, low burden, I think there is really an opportunity to kind of deal with what you can find, recognizing that there might be other things that show up, but at least you can eliminate the breast lesion as a potential source of new problems.
Since you brought up lymph nodes, can you freeze them?
It can be done. I mean, selectively. My preference is to remove diseased lymph nodes, but for people that do not want to have lymph nodes removed or may not need surgery because maybe they're stage 4, we can control the lymph node disease to some degree with cryoablation. It depends on the scenario. If it's a single node or a pair of nodes, then they're a better target than if there are 10 positive nodes. If the nodes are lower in the axilla, so that they're away from the large veins and arteries and nerves in the upper axilla, then that's a safer situation in which lymph node ablation can occur. It's important to know if there's a positive node, even if, and we see only 2 positive nodes, 2 abnormal nodes, it doesn't mean that the other nodes are normal. In fact, likely there are other abnormal nodes, it's just that they are not distorted enough to look abnormal. So just ablating the nodes you see and ignoring the others is not usually a successful approach. The best strategy is to combine, that ablation of the node with radiation of the remaining nodes, or medication, or both, because you have to anticipate that the additional lymph nodes have some level of microscopic disease that needs to be controlled in some way. And you can do that quite effectively with radiation, in addition to the medication you'd be taking.
Dental issues, gum infection and bleeding during chemo, anything that can be done. It's different.
Well, that's an outlier question, but I thought it was important enough to at least address, which is that, many people have dental issues, and dental issues can be a source of infection. As you know, a lot of the drugs that we give lower your white blood count, lower your immune system, and can make a dental issue quite a problem if someone has an abscess while they're getting chemotherapy. So, I want to make a plug for the importance of dental hygiene, but often before someone begins chemotherapy, they will have their dental exam. The oncologist will request a dental exam to make sure that their dental health is good, that they don't have any signs of an abscess or an evolving problem that could become a source of an worsening infection while they're on chemotherapy. So that's the main question. Then there are, of course, people that may have some periodontal disease. This needs to need to floss and do standard and brush appropriately. There's also this kind of a rare situation where sometimes you can have damage to the bone related to some drugs that are used for chemotherapy. But I don't think that really relates to the question that was addressed. So the main thing there is the importance of having a dental exam before starting chemotherapy to make sure that you don't have anything that will get worse while on chemotherapy.
Citrus fruit cravings during chemo, but docs are against any citrus, especially grapefruits. Do they really contradict with the chemo drugs?
Well, I searched for the answer to this question. For the most part, the only thing I could find there was clear linkage, but you'd have to talk with your oncologist about it, is that of grapefruit. Grapefruit does interfere with the uh, function of docetaxel, which is one of the chemotherapy drugs used for HER2 positive breast cancers. So in the context of HER2 positive discussion, it's important to know that one of the chemotherapy drugs that's commonly used for these patients may be impaired by grapefruit. So it's something to talk with your oncologist about. Obviously, people are on a range of drugs, and all drugs have their potential conflicts. So it's going to be important to know if there are any food contraindications for the particular drugs that they're on. But grapefruit is one that can be
Grapefruit
problematic.
seems to be indicated in a lot of medical stuff, a lot of drugs.
So it seems, yeah. So it affects certain parts of liver functions and the things that
Interesting, I didn't know.
process the anything that has to be processed through those organs can be impaired. So I think we've done pretty well with the
Got 9
time,
minutes left.
and we have 9 minutes
We
left.
have 9
We
minutes
just
left.
have to finish up early. Is there anything else you want to ask about that perhaps we didn't discuss?
I don't know, I did the 6 months of Herceptin, I didn't do the year.
Was that by choice or
That was by choice, but the oncologist I talked to, I interviewed 2 of them and neither one of them disagreed. They were fine with it. They were also fine with the fact that I didn't do any chemo with it.
Well, it's about finding the right doc to work with you. I mean, obviously there's sort of the standard of care, which is what we would generally recommend, but not everyone is willing to follow the standard recommendations.
Well, it
And
was
so-
interesting because I didn't even bring it up. They offered it to me without the chemo. So I don't know if it was my particular case was maybe different.
It might have been, but it's good to hear that there's some openness to it. I think that I see many people that have not moved forward with treatment because people weren't really willing to offer them antibodies alone because of a sense of responsibility or medical legal concern. The oncologist was only willing to offer the standard regimen, and so the patient sometimes sort of leave one place going to another to find someone who's willing to offer them a non-chemotherapy regimen without success.
Fortunately for me, I didn't have any argument from either one. One was from USC, and the other one was from a big cancer place in San Diego.
We know you're very persuasive.
No, I didn't even ask. They were okay with it. So,
But I mean, I don't want people to leave thinking that that's the best way to go. But
oh, I'm not saying that. I'm just saying for me, that's what they were willing to do. But of course, I think that the doctor I saw also made some comment that if it reoccurred, she'd probably want me to add the chemo.
It would make sense. Since we know that the best results were realized when there was a combination of the chemotherapy and the antibodies. So that will, I think what people should hear today, is that is a standard way to go, some combination of chemotherapy with the antibodies. But there are trials that are looking at other ways. Those are not prime time yet. That we don't know the outcome of those trials. They're not ready to be, utilized in the population in general. But if you are interested in that, I encourage people to participate in clinical trials, because really everything we've talked about today is a result of clinical trials. It's people that were willing to participate in studies to answer questions for which we did not have clear answers. Usually in clinical trials, you get the standard plus something.
Mhm.
You're not getting less than the standard but there are some trials where, uncommon, but there are some trials where they may, if it's a de-escalation trial, you may be getting less. The idea is that we're just trying to take the people who are best suited for that trial and offer them a treatment that helps to move the overall treatments forward. So clinical trials are very important. None of this conversation we've had today would have been possible without, the 3 decades of work that's been put into developing anti-HER2 targeted therapy. but it's been a lifesaver for so many women.
I think what's important though, is that you do something.
Yes.
I was not open to doing much of anything when I met you. But after all my research on the anti-HER2 therapy and watching the movie Living Proof, I opted to go ahead and do it.
That was a very smart decision. I think that I know some of this can be very confusing and very scary, but the cancers, they don't sit and wait for you to make a decision. Now, for some people with low-grade cancers or non-aggressive cancers, they may have more time because things happen more slowly with those cancers. But for the triple negatives and HER2 positives in particular, things happen at a faster clip.
Well, I had my cryo in September and I started my Herceptin in October.
That's excellent. I'm actually referring to those who, the time period between diagnosis and the first course of treatment. Sometimes that's a lot longer than
Well,
it
we
should
don't
be.
want to talk about how long mine was.
So, but for the benefit of everyone, the idea is independently that we have data to show that there's an association between, when you're diagnosed and when you
Mhm.
start the treatment in terms of your overall survival. Because again, very obviously, tumors may potentially spread.
And you don't want to let them grow.
And you don't want to have them grow because the more tumors you have, the more risk that there'll be mutations, the more risk that there'll be resistance that will emerge. And so you want to keep the lowest population you can, and so that until it's dealt with definitively. But sometimes because doctors aren't willing to consider a non-chemotherapy approach or whatever, patients let I frequently see patients that months or years pass without seeking treatment, and we have to be able to offer them something along the way.
Well, I can clarify in the sense of when I was diagnosed, nobody told me what HER2 was or how much I needed to do something right away. They just kind of left me in left field. And I had no clue what HER2 was until I met you.
Well, hopefully now all of you know what HER2 is and can tell your friends that it's one that does require prompt care and one that does call for openness to chemotherapy because the drug regimens are really miraculous. Not everyone gets a pathological complete response, but we're talking about pathological response rates in the 50 to 80% now, in 80 to 50% range now. Historically, the most we ever got was 20% of patients that had pathological complete response. So we have really, particularly for this type, we really have really changed the game for what can be accomplished with pre-treatment. So I think on that note, I think we should wrap up and plan for the future. We've had some conversation before we got started, and we decided that we'd do another breast cancer Q&A webinar August 13th. And the topic will be triple negative breast cancer, which is like chemotherapy, like HER2 positive breast cancer, is one of the particular ones that require some intensive and proper care because of their tendency to grow and spread at a much faster clip. Mm-hmm. So triple negative breast cancer, August 13th, 2022. See you there. This video has been recorded and we plan to have it posted within the next 24 hours to YouTube.